On this episode of the Athletic Potential Podcast, we will be discussing spinal health basics, as well as what is the hardest part of the rehab process following Tommy John surgery. Welcome to the Athletic Potential Podcast, your place to come and get answers to your athletic development questions. We cover a range of topics, all related to helping you to achieve your athletic goals so that you can experience and enjoy the athletic career that you deserve. I am your host, Dr. Mike Matthews. Hey everybody, and welcome back to the Athletic Potential Podcast. And today we're going to take a few questions and kind of get back to our normal format in regards to the podcast. Our last episode, we had John the student on. We discussed the soccer conditioning program, which we have continued to implement, and it seems to be going fairly well. And so that's good news. If you didn't hear that, go back to last episode. But today we're going to go back to our normal format and take some questions and see if we can give some good answers. So as a reminder, if you do have questions for the podcast, there's a link. If you're listening to this podcast through Apple Podcasts, there's a link on the show notes. And if not, you can go to the website, www.athletic-potential.com/podcast. Click on the button, ask a question. And we'll answer any and all the questions we get. All right. I appreciate it, and let's jump right in. So our first question comes from Matt, and Matt says, as a physical therapist, I'm sure you see a lot of patients complaining of lower back pain. When it comes to lower back pain, what are the first 2 to 3 things that you prescribe to each one of your patients to get them out of back pain and back to normal life? Matt, great question. Here's the deal about back pain. I can tell you right now, it really, really, really depends on what kind of back pain you're having. And so I can tell you right now, I don't prescribe out the same thing for every client. I prescribe out similar things for every client. And I think the best way to answer this question, Matt, is to give you kind of the framework of what I typically go through with clients to make sure that we get them first out of pain, second, functioning without pain or without the pain returning, and then third, getting them so that they have this long-term health, spinal health, that it persists and their back pain comes back or never comes back or rarely comes back. And if it does come back, they have the tools to deal with that pain immediately, and then it keeps it from getting really bad. So let me put it this way. So Matt, it really depends on how old you are, a little bit on gender, a little bit on regards to how your back pain started, why it started. I mean, obviously there's a big difference if you're having back pain, if you got in a car accident, and now all of a sudden you're having lower back pain versus, hey, I just went over to pick up a piece of paper off the ground to throw it away and my back went, and now I can't even stand up straight. Those things are totally different and treated totally differently to an extent. So let me do this, Matt. We're going to walk through a framework. I'll do my best to kind of lay it out in a simple manner, and I'll try and maybe have to come back and put it back out into a framework so that it makes more sense. But let's start this way. Now, look at this. When it comes to back pain, and again, subtle nuances, those that are listening that know anything about back pain, they're going to be like, well, that's not true if this is going on. That's true, but let's just try and generalize this a little bit. Okay? Most back pain, when you start having back pain that's non-traumatic, meaning that you did something that would normally not hurt your back and now your back hurts, okay? Picking up a piece of paper, picking up a pencil, even like lifting a lighter box or a box. We've lifted all these boxes before, and then for some reason today, bam, now your back hurts. Those kind of things. Here's the first thing you have to do, and it'll sound completely revolutionary. I'm being sarcastic. You've got to stop doing the things that are producing your pain. So in my world, we call those pain triggers. You want to avoid all of your pain triggers, okay? So if that means it hurts to sit, then you're going to try not to sit. If it hurts to stand and walk, you're going to try not to stand and walk. If it hurts to write, sit at a computer, do household chores, any of those things, if you're in pain during those activities, that is triggering your pain. And the reason why that's bad is not only because you're in pain, but the other reason is because your spine becomes sensitive. And the more sensitive your spine is, the more things in your general daily life are going to create pain. and eventually going to limit you to the point where you're not going to be able to do much because it hurts so bad. So here's a bad analogy. I'll be honest. I should probably refine this before I put it onto a podcast, but we're going to try it anyways. So here we go. This is something I tell my clients. And when we talk about spine sensitization, okay, if you're a parent, you'll understand this. If you're not a parent and had siblings, you'll still understand this. If you are not a parent and never had a sibling, you can have to imagine it. Sorry. Okay, so here's the point. You're driving down the road. Say you're the parent. You're sitting in the front seat of the car, driving or in the passenger, doesn't matter. And you got two kids in the back seat. And the kids are sitting apart from each other, but next thing you know, it's a longer drive, and so the one kid looks over at the other kid and reaches out with one finger, and starts poking him, pokes him in the leg, arm, doesn't matter. They're just poke, and the one sibling looks back, and goes, "Hey, I need you to stop poking me. It's not my favorite thing in the world." And the other sibling looks at him and he goes, "Okay, poke, keeps poking." Sibling looks back at you like, "Hey, yeah, not cool. I'm not really excited about it. I really would like you to stop." First sibling comes, looks back, poke, keeps poking. The being poked sibling looks at him and goes, "Seriously, dude, I want you to stop poking me." And the sibling looks back at him and goes, "Okay, I'll stop poking you." And poke. Next thing you know, sibling looks back at him and goes, "Stop poking me!" And he's yelling at her or him now. And next thing you know, now you're in the front seat driving, and all of this blows up behind you. You turn around because you're sitting in the passenger seat, not driving. The driver continues to focus on the road, but you turn around. "Hey, everybody, calm down. Stop poking. You keep your hands to yourself. You need to calm down. Everybody look the other way, look out the direction," whatever you normally do, right? So everything's kind of hyper sensitized. Everything's just blown up. Everything's crazy from a small poke, right? Now it's blown up. All right. So now everything's sensitized, right? Everybody in the car is a little on edge now. Okay. Now, how long do you think would it be? Okay, let's put it this way. How many pokes would it take for sibling A, who's the poker, to poke sibling B, who is the pokey, right? How many pokes now would it take? It probably took 50 to 100 for that person to go and blow up and be really upset and angry. How many more pokes do you think it would take for that to happen again? I'm willing to bet like 5, having kids. 5 to 10 pokes, poke. "I said stop," right? And it blows up. And we call that sensitization. And in the spine, that's exactly the case. So you poke it enough, poke, finally the spine goes, "I'm done." Boom, it blows up. You get massive amounts of pain, and everything's just really hypersensitive. Every movement kind of hurts. You back off. That's everybody just kind of looking out their windows, out the side. Nobody's poking anybody, and you're relaxed. Well, you give it so many hours or however long it takes within a day. You're like, "Oh, okay, I feel a little bit better." You start getting up. You bend over to pick up something. "Ooh, that kind of hurt. Ooh, that kind of hurt." You bend over third time to pick up a pair of socks. Bam, your back blows up again. You're like, "Why is this happening? I only bent over 3 times. Well, you only had to poke it 3 times for it to go big time again. And that's called sensitization. So coming back to it, out of that analogy is when you're in a fair amount of back pain that's non-traumatic, okay, it's just come on from daily activities and all of a sudden now it's bad, your spine is hypersensitized. And what the first thing you have to do is get it to desensitize. The only way you can do that is by not poking it. You have to get rid of those pain triggers, those things that were causing it to hurt in the first place. If you don't know what those are, there's a way to figure out. It's called, what hurts? Write it down and just keep writing everything down. Okay. And then go back to yesterday. What normally hurts? And just what you'll see is a pattern. Okay. You list out your pain triggers and you go, "Hey, look, it looks like it hurts every time I lift something and bend forward." Right. And it could be a lot of things, but realistically that there's a very common combination there, right? Oh, it hurts when I lift things, or especially when I'm bending forward all the time. Okay. Well, that's a pain trigger. So what do you need to do? You need to avoid those activities for the time being until your spine becomes desensitized. Now, during the desensitization process, your spine pain goes down, right? We know that because you're avoiding all the things that hurt. So now all of a sudden your spine pain is down. Now, normally I see clients when they're in a lot of pain. So I walk them through all of the spine desensitization process. I tell them the positions to get into, right? So look at this. This is what I'm trying to get at, Matt, is you talk about writing down your pain triggers. So now you know what hurts it. Now you need to go list out what's the alleviators, what makes it feel better, right? oh, you know what? I had a client say like, look, the thing that makes this thing feel better is I lay on my stomach, with my hands underneath my forehead looking straight down. I lay there for like 10 minutes, 5 minutes. I can't remember what he said, is minutes. And my back pain just slowly whittles away and goes away. And I'm like, okay, well, there's a pain reliever, right? We call that a recovery position, whatever you want to call it. Maybe laying on your side in your bed. It may be laying on your back with your knees bent in your bed. It may be the opposite. The key is that it doesn't matter. There's no specific position. Matt, you're asking me, well, what's like 2 to 3 things I prescribe out? I can't. I have to know what's pain alleviating and what's pain producing. And if I know those things, I'm going to be like, boom, here's what you're doing, right? And here's what you're not doing. And so once you know the pain triggers, you avoid them. Once you get your pain alleviators, you write those down and you try to stay with those as much as you possibly can. Okay. So now we're avoiding the painful things that hurt. We're doing the painless things, or the things that make it feel better. Now, here's where everybody goes. I feel like people go awry. Okay. And that is they're going, I do these things. And more often than not, you're down and out for 24 hours or whatever it is, right? Back attack, whatever you want to call it. But you're down and out. You avoid all the things that hurt. You do all the things that make it feel better. Okay. And some things are better. Like there's a lot of variants. I know everyone's like, well, what about this? What about that? I get it. Like if you have back spasms, you got to get rid of the back spasms. Well, they get rid of back spasms by getting in the pain relieving positions and staying there. Now, everybody's results will vary. Some people, it takes a long time. Days, weeks. I hate to say weeks because I've only ever seen it go like 10 days before for things to calm down. Right. And we'll talk about extreme cases in a minute, but the idea is this: avoid the things that hurt, find the things that don't hurt, and live that lifestyle as much as you possibly can for the next 24 hours. If your pain levels have dropped below a 3 or preferably to 0, great. Here's where people run into trouble. Is now the pain is gone, the feedback system is gone. The ability to know what's good and bad for your back is now inherently gone because it doesn't hurt. So what I tell people now is you need to keep that pain trigger list. And at this point, you need to look at it and say, it hurts when I bend, it hurts when I lift, and it hurts when I do this, whatever it is. And now you've got to design 2 things. 1, an exercise program to help your spine avoid those positions. And 2, to design a lifestyle or find the things that you are doing in your life that are putting your back in those positions. Now, in my world, the first one, okay, is a core program or whatever you want to call it. Okay. I typically call it a spine stabilization program because more often than not, I'm teaching you where to keep your spine. So the core program comes in here. Okay. This is bracing. This is bird dogs and curl ups and side planks or side bridges. Okay. Nothing more than that really. Okay. But those are those things that I typically prescribe here. So if you want to look at those, go to my YouTube, search Big 3. It's Stuart McGill's work. Okay. He's a spinal researcher out of Canada. And those are the big 3 that he uses. And I've already mentioned them. That's the side bridge or side plank, bird dog, and a curl up. And if you don't know what those are, go to my YouTube, look at the videos. Okay. Those are typically the exercises I give out. Now, the second thing is what also Stuart McGill calls is spine hygiene or spinal hygiene. Just like you brush your teeth for dental hygiene, right? You bathe your body and wash it for body hygiene. There's such thing as spinal hygiene, and that is you are doing things to spare the spine of stress. Okay? This looks like how you roll over to get out of bed, how you brush your teeth, how you do the dishes, how you vacuum the floors, how you mop the floors, how you pick up objects in and out of a car or from a low surface, how you, comb your hair. These things are all spinal hygiene. And the key is that there's research out there, good research out there suggesting which activities create more spinal compression, stress, whatever. And if you do these things in the right way, you'll decrease the amount of stress that are going through your back and through your spine. And therefore will decrease the amount of times you're poking it before it blows up, or hopefully it never blows up and you're fine, right? So that's what I tell everybody, like the stage 2 of this. So stage 1, identify your pain triggers and pain alleviators and get yourself to a 3 out of 10 or less on the pain scale as soon as possible. Once that happens, stage 2 becomes, I need you to do these core stabilization exercises to make sure that your body can actually control its spinal position. And I need you to start practicing good spinal hygiene. Okay. This is fairly intricate. This is a lot of information in spinal hygiene. Okay. I spent a lot of time helping people with this. We're teaching good movements here. We're teaching the hinge and the squat and the proper way to do different things, right? That's phase 2. If you get through all of phase 2, showing good spinal stabilization, and you're finding good spinal hygiene, and your pain levels in your back are 0, hopefully. Sometimes they may creep to a 3, but very infrequent, 3 to or less, or 0 on a 10 scale for a certain amount of time. And a certain amount of time can range anywhere from 2 weeks to 2 months, realistically. If you can do that, then we move to phase 3, and phase 3 is about core conditioning, making sure that we start building the resilience of your back by doing good movements and teaching you to lift loads. This looks like strength training, okay? If you can do that and get into phase 3, this is where we start building backs to be very durable and to be very resilient to future problems. Now, here's the thing, Matt, and I tell everybody this. If it was simple, everybody would be doing it. Sorry, if it was easy, I always get that wrong. If it was easy, everybody would be doing this. The hardest part of this is that it takes a lot of discipline to make this work. Okay. The program is fairly simple, right? We just talked about it. Avoid the painful things, do the things that don't hurt, get yourself down out of pain. Once you're done there, you need to do these exercises, whatever those are, and you need to practice good spinal hygiene. By far, one of the hardest parts, the spinal hygiene thing. This is all the things that you are doing to make your back mad. You need to redo them and rethink how you do them and reprogram your brain how to do them and do them better. Hardest part. I don't know if it's the hardest part, but it's one of the most difficult parts. Change the way you've done things for years. That's hard. And then once you're done there, then you start doing the stuff you want to do, right? I want to go weight train. I want to do all this kind of stuff. Yes. And you got to do that smart with back health in mind. Once you have done that, you build a resilient back, and you should be able to move forward as long as you maintain those levels of good strength and core stability and spinal hygiene for the rest of your life, and you'll be good. By the way, as you age, spine changes and things may creep up and do different things, and you may have other things you have to deal with. Concepts are the same. All right. So Matt, bringing it back, because I know we went a little bit on a tangent here, and I want to make it clear. The things that I prescribe to each and every one of my back patients are the first thing to do is we got to get you out of pain. Find your pain triggers and avoid them. Find the things that make your back feel good, and let's do more of that. Okay. That's the first thing. Second thing, you're going to do a very basic core exercise program, typically McGill's Big 3. Okay. Followed by practicing very good spinal hygiene. You got to relearn the movement patterns that have produced your back pain at this point. Once you're done with that, then we're going to go build a resilient spine through good strength conditioning. And from there, you're going to be able to move forward. So, Matt, I understand one thing that this question did not do probably for you, and that is did not give you a very specific protocol to go follow. And the reason is I can't do that because back pain is that specific. We have to identify really what is the root cause of your back pain and start working to decrease all the things that sensitize your back and create those problems. And those are typically very, very individualized. I can tell you this. I was taught something out of school. It was a great program. It was laid out. It was a nice algorithm. And it was fun to go through. And you're like, oh, yeah, I'm going to do this. Okay, patient did this. It's basically like this. If patient has this, you go this way. If the patient has this, you go this way. And then you just keep following the algorithm tree until you get, to a treatment option, and then you do that treatment option. I'll be the first to tell you, I did that for a while. My back pain patients just didn't respond very well. The algorithm wasn't good. And because what we're not addressing were the poor movement patterns or the pain triggering movements. If we don't address those, I don't see anybody's back pain really getting better in the long term. Now we talk about, one of the things we talk about, injections, those definitely help. But the problem is the injections only fix the symptom at this point, okay? But they can help us if we've already got everything else on board. Like we're trying to improve your movement. We're trying to improve, your spinal hygiene, but you're having so much pain. Everything's so ramped up. We use the injections to knock everything down. And then you keep practicing good spinal movement and spinal hygiene. That really helps. But just know that I've seen spinal injections take pain away. Gone. For long periods of time. But here's the deal. I should say a lot of the time, I see that come back. Or I see a different version of that pain come back. And it's a little dissatisfying, right? I just don't see in my practice, in the clients I've treated over the past 12 years, back pain will not resolve without changing the way you move that caused your back pain. Now, remember, I'm talking non-traumatic, like non-car accident, non-falling, non-the stuff. This is the stuff where you're just doing normal daily activities. Now your back hurts, okay? And that kind of back pain, you've got to change the way you move, because the way you move is most likely created the stress on the spine that is now creating your back pain. If you fix those things and do so over a long period of time, I just said the hardest part, over a long period of time, your back pain should dissipate and go away. All right, Matt, I hope that helps. Major tangent, but that is the system that I use. And I can tell you this, I have seen dramatic success to the point where I had a couple of clients that were scheduled for surgery. Okay. Scheduled to have surgery. They were told 100%, hey, 5 years ago, you're going to have surgery. And they're like, yeah, I think I'm ready. Right. And they came to me for whatever reason. And I said, look, here's what we need to do. I want you to do these things. Let's work through this, and I'm going to say it again, make sure nobody misses this. 6 months later, they are out of back pain. I didn't say 6 weeks. I didn't say 6 days. 6 months later, they were doing everything they wanted to do and had no back pain without surgery. Okay. It takes time. It just takes time. Okay. Now, we found ways to speed it up, yes, but in the end, it takes time, diligence, effort, and consistency for this kind of stuff to go away. So, Matt, I hope that helps. All right, let's move on to our next question. The next question comes from Julio. Julio says, or asks, asks, I know you have rehabilitated a significant amount of players that have had Tommy John surgery. My question is, what do you feel like is the most difficult part of the rehabilitation process, and what are the best ways to make sure that you get through that through that part of the process without any major problems or complications? All right, Julio, this is a great question. Okay. There are a lot of different ways to answer this question. Excuse me, hold on. And let me put it this way. Let me answer this question, Julio, where I see most of the issues come up in the rehabilitation process. Okay. And I'll tell you a story. And I apologize for those listening, is maybe not the most entertaining thing in the world, but let me tell you a little bit of history. So I opened Athletic Potential just over 2 years ago. And before that, I would treat a lot of baseball players and softball players. And I was working at what we would consider like a more traditional outpatient orthopedic physical therapy clinic. We really had no place to do any throwing. We had no place really to do any like significant return to sport throwing type testing. And so here's how this worked. So I'd get clients and that would be sent to me for baseball injuries. Okay. And some of this, I think maybe a few of these were Tommy John patients. They would come to me and I'd say, okay, great. Here's the thing. We got to get all your range of motion back. Then we got to build up all your strength in your forearm and your shoulder. Then we got to work on your core and balance. And once we've done those kind of things, and we're going to put you through a light plyometrics, double arm plyometric drills. Then we're going to go through single arm plyometric drills. And once you've done that, by then usually you're at that time frame around the 3 to 4 month mark where you should be able to start throwing. And then when that came to that point, they were pretty much done with physical therapy because now they're onto their throwing program. So I would then hand them a sheet with their throwing program, say, hey, here's your throwing program, go do it. And then I said, but I do need you to follow up with me in about 2 to 3 weeks after you've gone through a throwing program. So at about 2 weeks or 3 weeks later, the patient would call me, get back into the clinic. We would sit down and I'd say, hey, how's it going? And they'd be like, you know what? It's going pretty good, except I'm getting some pretty good elbow soreness and pain. I would check their range of motion would be they'd have lost range of motion in their elbow, and they'd have pretty good soreness and sometimes significant pain in their elbow. And I'd be like, oh, well, tell me what happened. What's going on? And basically, without prolonging the story, is what happened is they'd go out and do the throwing program and they wouldn't do the throwing program correctly. That's on me as a clinician. I did not teach them what to do. I just handed them a piece of paper and said, here's what you're supposed to do. Go out there, throw 60 feet for 45 throws or whatever it was, right? I've changed my throwing program so much I can't remember, right? So it's like, go out 60 feet, 15 throws, rest, 15 throws, rest, 15 throws, whatever it is. And then you do that day. The next day, you're going to do the same thing. The next day, you're going to advance it. And then whatever, you go do it. Okay, great. Follow up with me in 2 weeks. Now you're back here in 2 weeks and you're telling me you've got elbow pain. Well, when did you start having elbow pain? Well, I started elbow pain in like my third throwing session. I'm like, whoa, that's not okay. Like, we shouldn't have elbow pain yet at all. Soreness, yes. Pain, no. So now we're looking at this and I'm looking at you going, that's not good. So here's what I did to negate some of these problems that we were having with this return to throw programming. Okay. And that is, I said, okay, great. Hey, you just passed everything. Everything's ready to go. It's time to start throwing. You're going to come back with me and you and I are going to go throw. And so what we'd do is I'd schedule a time with that patient. The patient would come in. We'd walk to the park that wasn't too far away from our clinic. I'd go out and I'd take them through their first day of their throwing program and teach them what it was supposed to be done. Now, I'm thinking, okay, this is good. This is what I want, right? Okay, great. I do the first version of the throwing program. Here's how you do it. Advance it this way. See me in 2 weeks or 2 to 4 weeks. Come back in 2 to 4 weeks. Same as kind of initial problem as we had before. And that was still has soreness, still has pain, is pushing through things, is throwing too hard, is throwing too soft, whatever. So then natural progression for me was, okay, great. I'm going to take another visit at 2 weeks or 3 weeks, and we're going to go out there and throw again and make sure that we're doing this correctly. You can see where this is going. I went from not throwing with my clients to then throwing at least the first session with my clients to now throwing one every 4 to 6 sessions or 4 to 6, throwing sessions with my client. And that progressed to the point where I told them for the first 2 to 4 weeks of their throwing progression, they were going to throw twice at home and twice with me. They would come in twice a week. I'd go throw with them. They would throw the other 2 days of the week on their own or with whoever. And then we got this. Guess what happened to my outcomes? They went dramatically up, meaning they all got better because of the supervision of the process of the throwing program. Fast forward, all of a sudden, and let's be honest, I don't have that much time to go out and throw with one of our clients in a park. Okay, I just don't. Unfortunately, this is the situation that I was in. We were a busy clinic. I didn't have that much time to go out and come back and treat and then go back out again. If I had multiple clients. And what I've basically found was we were able to get all of our clients through a throwing progression, and they did great. Well, guess what? I didn't have at the clinic. I didn't have a park. Guess what I didn't have at both the clinic and the park? I didn't have a mound. I had no pitching mound. And so if they were a pitcher and we were trying to get them back to pitching, I'd be like, okay, great. Here's your return to mound protocol. Go do it. And guess what would happen? A week later, 2 weeks later, they come back and they'd be sore or, hungry. And I'm looking at this going, man, I am a terrible clinician. I am not instructing my clients very well to go out and do this on their own. They're going to have to do it on their own. What do I need to do? So what did I do? I essentially still didn't have a mound, didn't have a park with a mound in it. So I basically said, look, here's your iPhone. You're going to hit record on video, and you're going to video your first mound progression, and then you're going to send it to me, and we're going to review it. And that's what we did. And guess what happened? Outcomes and return to mound protocols went dramatically up. Now, around this same time period, I was starting to see a lot more basic clients, and things just kind of worked out that I left that outpatient orthopedic clinic, and then I came and opened up Athletic Potential, where we have now a facility that has indoor turf, mounds, bullpen, everything we need. And so now guess what? All my outcomes are dramatically better. And that is because we were able to monitor each phase of the process. Now, getting back to your question, Julio, what do I feel like is the hardest part of this rehabilitation process? If the first part of the rehabilitation process is done correctly. Now that's a big if, okay? So you've achieved all range of motion in the elbow. That doesn't mean just bending and extending. It means rotation as well, pronation, supination. And then also demonstrated good throwing mobility in the shoulder itself, meaning you have proper external rotation and internal rotation and flexion in addition to the other motions, but then you also have proper strength, proper endurance, proper EMG. I mean, all these things we can talk about. If all of those things are done correctly in the first 0 to 3 months following surgery, okay, then you don't run into problems during that time period. Now, I'll be the first to tell you that this is usually the area where we don't run into a lot of problems, and the reason is because most of the time, clients that are going through this return to, or through Tommy John surgery, they're highly supervised at this time. They're going to physical therapy multiple times a week. They may be doing a strength conditioning program with a strength coach in conjunction with their physical therapy. This is not a time where we see as many issues so long as the rehab is done correctly. And as long as it's done correctly, all those things I addressed and talked about, in addition to more, if that's done right, this initial part is not the problem. Okay? Where we start to see issues is where supervision decreases and we're starting to return to throw. I think that is the biggest speed bump, hurdle, whatever you want to call it, that we run into. And I've spent some substantial amount of time. Sorry, I could not say that. Substantial amount of time trying to make sure that part of the process is no longer a problem. And good news is now we got great technology that helps us with this. We got videos. You got iPhones that can video anything. We're starting to do different programs with stress monitoring in regards to using velocity measurements because pocket radars are so available now, or any other velocity or radar measurement tools. We started using it that way. There's wearables now that can kind of give us an idea of arm stress. There's a lot of different things that we can do to monitor a throwing program now. And if done correctly, the throwing program becomes something it's not a problem anymore so long as, again, it's monitored and done correctly. And that's one of the hardest parts. And so to answer your question more directly, Julio, I think one of the hardest parts of the rehab process following Tommy John surgery is the initial start to the return to throw program. So this is your interval throwing program. You're not pitching. You're not off a mound. You're literally just starting to throw, because this is where soreness creeps in. This is where some ornery stuff starts to happen in the arm because the arm hasn't thrown in 4 months, which is probably the first time in years that the arm's taken 4 months off of throwing a ball, which is good and bad. And there's just a lot of changes going on. And so I think this is probably one of the hardest times in regards to the Tommy John rehab process is that return to throw time. Now, I can tell you in my experience, Julio, we monitor this heavily now. Most physical therapy programs, especially if you're going through insurance, will end at 3 to 4 months, basically when that return to the throw program starts, because insurance typically stops covering that type of thing. They look like, we're not doing return to throw, we're doing all this. You've got lack of motion and strength. Like, we can document all that. We're not paying for anything beyond that. That's return to sport, right? That's what most insurances are going to stop. I can tell you right now that I have a lot of clients that will go do physical therapy somewhere else because it's more cost effective, right? I mean, they almost have no copays and all out of pocket specs, so they go somewhere else. But I always tell them this: I need you to come back and see me before you start your throwing program. Let me tell you this. Your physical therapist is going to say, hey, yeah, you're ready to go. Here's your throwing program. You're good to go. Go ahead and start it. Your surgeon's even going to say the same thing, okay? And we have an amazing surgeon in our area that we work with that does most of our Tommy John's and UCL repairs. And he hands them a program. It's great, right? It's great. But I tell them anyways, look, you need to come see me before you do this. There are a few things, and I call it a return to throw assessment, that you need to be able to show me that you can do and pass before you start throwing a baseball, because it won't hurt the first 2 times. It'll hurt the 3rd, 4th, or 5th time, and we're going to run into problems, and you're going to have to shut it down and wait longer. If we do this correctly right now, you will avoid downtime later, having to take downtime later because of you were just not quite ready enough. Okay? So they come to see me through return to throw assessment, and what I normally want them to do, and most people will end up doing, is this. They'll do that, and then what we'll do is we'll sign them up essentially and say, look, you're done with your formal physical therapy. I'm going to take you through a return to throw program all the way back to you face a hitter in a game. And that's what we do. And I can tell you right now, Julio, since we have done that, the amount of guys that have returned to pitching at the same level as previous, meaning throwing the same velocity and able to compete against us at the same level they did previously, has dramatically gone up. You look at the research, it's 90%. 90% return to the same level of competition as previously. And I can tell you that is our result. At least 90%, probably better than that. And since we have started to monitor the process and really make sure that everybody gets through each phase of the process, including the throwing program, the return to mound program, okay, and the return to game program, if they can do those things and it's monitored and done well, there's a great chance that everybody gets back. And nearly everybody. I mean, we're talking 9 out of 10. And that 1 out of 10, it just takes longer sometimes. Okay. Julio, it's a great question. All right. And I appreciate it. And it's something that we deal with every day. We're in the kind of the midst of it right now in a lot of ways, but it's, if you can monitor every phase of the process, especially the throwing program, your chances go up dramatically being able to return back to the same level, if not better than you were before. So, but thanks, Julio. I appreciate it. And thanks, Matt, for your question as well. And I appreciate everybody tuning into the Athletic Potential podcast. It's always fun to answer these questions and to kind of think about things and make sure that, everything we're doing here is up to date. And I can tell you, we got a few, some fun, exciting things that are going on right now at Athletic Potential. We've got some new programs coming on board, some things that we're starting to see, seeing some pretty cool results in some of our some of our athletes and our new treatment protocols that we have. And so I hesitate to talk about them right now because I know there'll be future podcast episodes on them. I don't want to just do a case, a one person case success story because it's not as powerful, but I can tell you right now that we've seen more than one come back from some of these new protocols at a faster rate than I've ever seen in my previous 10 years of practice. So, and I know that's a big claim, and I don't want to sound sensationalized or anything like that, but it's always fun to see how changing the protocols can get our athletes back out there and get the athletes out there playing and performing where they want to be. I mean, that's the whole point, right? We want to get you back out there. So I appreciate you taking the time to ask questions. And if you have questions, please submit your questions. We'll get them answered. And I appreciate everybody taking the time. And until next time, thanks. Hey everybody, just want to say thank you for listening to the Athletic Potential Podcast. If you do have questions for the podcast, please visit the website, www.athletic-potential.com/podcast. You'll find a button there to ask your question. Please input your information and your question, and we will answer any and all questions we get. And thank you again for listening. If you do get a chance, please rate and review the podcast. And until next time, thanks.